Welcome again, as I say, to this afternoon's COVID-19 question time webinar. Your questions and answers on COVID-19 kidney disease, particularly protections and treatments. We're hosting the webinar this afternoon, but we've got some fantastic speakers who are going to be working with us to answer the many questions that you have sent across, which I thank you very much. Alex, I wonder if we could just go on to the next slide, please, while we introduce how the session is going to work this afternoon. If you are someone that tweets, you can keep the conversation going there using COVID question time. As I said, thank you so much for all the many questions you've sent us. We plan to address as many as possible today. If you've got technical issues, you can't hear me, there's things going on there, do post them to the chat box. I'll have a go at trying to sort those out. If you have personal medical questions, please do talk to your own kidney team. We won't be able to answer those directly during this afternoon's webinar. The webinar is being recorded, so if you miss a bit, don't worry, because you can listen back again later on. And it will be made available on YouTube with some subtitles. We'll also, in about a week's time, be publishing a summary report, which you'll be able to find on the Kidney Care UK website. So let me introduce you to our speakers. So if we could go on to the next slide, please, Alex. So what I should say is I've got a fantastic team of Kidney Care UK colleagues on here. That's Alex, who's working the slides, Sharon, who's doing the social media, Sam, who's my policy colleague, and a whole bunch of other people here who are helping to run the webinar in the background. But more in the foreground, I'm pleased to be able to introduce Dr. Laurie Tomlinson. And if you could, our speakers could just switch their cameras on as well so people can see you as you pop up. So that's Dr. Laurie Tomlinson, who's kidney doctor at University Hospital in Brighton. She's also the Associate Professor of Epidemiology at the London School of Health and Tropical Medicine. I think I've got that one right. We then have Ms. Claire Morledge, and she is the lead renal pharmacist at the Eastern North Heart Hospital, the Lister Hospital, as some of us know it, and president of the UK Kidney Association multi-professional team. We then have Dr. Michelle Woolacombe, who's a kidney doctor who's been on a number of these webinars before. Many thanks, Michelle. And she is at Imperial College NHS Trust, and she has a research interest, particularly in transplantation, and a whole range of other things as well. And finally, I believe we have David Hayward, who's Deputy Director from the Antiviral and Therapeutics Task Force from Department of Health and Social Care, who will be joining us at some point. Okay. What I'd like to do then is just summarise out what we'll be covering this afternoon. We divided your questions out and we've allocated them between different speakers, but it may be that others join in depending on the question and how the discussion goes. So we're going to kick off with Laurie, Dr. Tomlinson, talking about the current risk from Evusheld. We're then going to be hearing a bit from David Hayward from the Department of Health and Social Care about some of the current policies on COVID treatments in Evusheld, and also hearing from our own experts on those matters. We're then going to talk about the spread of COVID, because you asked us some questions about that, plus how COVID affects the kidneys. Again, these are all reflecting your questions. Talk about vaccines, where are we at with them? Vaccine safety. We're going to talk about antibodies, what place they play in this. And we're going to round up with some pieces about socializing, safety at Christmas, and so on. So I'd like now to just jump on one more slide, please, Alex, which is we're going to, as I say, start with the current risk from COVID. So if you could take the slides down, please, Alex, and I'd like to hand over to Laurie. Perhaps you could highlight Dr. Tomlinson there. And so thank you very much for joining us this evening, Dr. Tomlinson, or Laurie. I'll probably call you during the meeting if that's okay. And the other thing I just realized I forgot to do, despite writing it in very large capitals, I didn't introduce myself. So I'll just do that really, really quickly. So I'm Fiona Loud. I'm Policy Director for Kidney Care UK, and I also live myself with kidney disease and a kidney transplant. So just goes to show you can write these things down and you still don't remember. So Laurie, back to you. I wonder if you could just start by just giving us a little bit of a rundown. Is COVID still as much of a threat to us as it was at the start? And just a little bit of background on the current COVID risk for kidney patients. Thanks, Laurie.
Thanks, Fiona, and please definitely call me Laurie. So it's been obviously a very tricky 2.5 years now. And I think the risk has changed quite a lot over that period of time. And I think it can be quite hard for people to keep up. And you're hearing conflicting stories and seeing things on social media, which can be very scary. So overall, the situation's dramatically improved since the beginning of the pandemic. We have really effective vaccines, although there are issues about that, which we'll come to later. We've now got treatments for people who develop COVID, and we've got treatments for people who get really sick from COVID who are in hospital. So overall, the picture's hugely better than it was. And kidney patients, all the way through from mild CKD to patients who are on dialysis and with kidney transplants, have been particularly affected by COVID for a whole range of reasons. And the risk of them becoming severely ill was much higher than other population groups at the beginning of the pandemic. And that's why they were highlighted for early vaccination and for other treatments as well. But the risk of getting sick from COVID now is much, much lower than it was at the beginning of the pandemic. And I'm going to show some numbers in a minute to highlight that, but things are much better. So the rates of people getting sick, going into hospital and sadly dying are all much lower than they were. Because kidney patients are more affected than some other population groups, the comparative risk is greater than an otherwise healthy person. But that doesn't take away from the fact that overall the risk of getting severely ill is dramatically better. Did you want to say any more, Fiona, or should we move on to some actual data? Or you're on mute.
Of course I'm on mute. That was a great start. You'd think I'd know by now. Yeah, I just wondered if there was anything that you wanted to say now, but we can go on to it later on, if there's any particular difference between people with early and moderate CKD, people on dialysis and people with transplants, because that's several of the questions we've had. So perhaps just a little bit on that, please.
Yeah. So what we see is this kind of progressive increase in the risk of becoming more unwell with COVID, right from people who have early CKD right through to the highest risk groups, which are patients on dialysis, in-centre dialysis and kidney transplants. But now, as things have improved overall, all of that risk has shifted a bit. So the patients who've got very mild early kidney disease, their risk is much, much improved and not really different from other patients in the population. And obviously it depends on other things that you might have, so diabetes or cancer or other conditions that might be related. So that dialysis and transplant patients remain at the highest risk, but overall much lower than they were previously.
Mm-hmm. And because we remain at the highest risk, although the overall risk has gone down, that is why we are still talking about vaccination, treatments, prevention, and which is much of the subject of this webinar this afternoon.
Exactly, and that's why the risk has gone down. It's not magically gone down because COVID has become less severe. It has gone down because of lots of people being infected in the population and vaccination, is absolutely essential.
Great. Okay, thank you. And I've just got one other quick question here before we go on to some of the numbers and things. If you've had COVID once and you were okay, is your outcome likely to be the same the next time you've been infected?
Many of these questions, probably a lot of the answer is going to be we can't be entirely sure. So we do know that you do build up, or most people will build up substantial immunity, and that subsequent infections may be much less severe after the first one. But COVID itself is continually evolving, and it may be that there are other variants in the future which may escape some of our existing immunity and be as severe again. And so it's really important to keep listening to medical information, especially if new vaccinations are being called for or if new treatments are being recommended.
Okay, lovely. All right, thank you. Now, I wonder if I could ask Alex just to bring up those couple of slides. Now, for people who are on the phone, we realise that you may not be able to see all of these. I think there's 3 slides, and Laurie will talk you through them anyway, and you can look at them afterwards too. The first one is a picture anyway. So Laurie, over to you just to describe those. Thank you.
Absolutely. So these are all just data that you can find very easily via Google, and there's some really, really brilliant websites out there that will provide this information, you know, one click on Google. So this is data from the Office of National Statistics Coronavirus Infection Survey, which has been absolutely fantastic in giving us really great detailed information about how many people in the population have COVID or are infected with the virus that causes COVID at any particular time. And so for those who can see the screen, you've got the ups and downs of the infection rates in the population over the period of the pandemic. And right on the right-hand side screen is the most recent data that we have, which is coming towards the end of November, so a couple of weeks ago now. And the last data that we had was that only around 1 in 60 people, if you've swabbed them, would have tested positive for the virus that causes COVID-19. So pretty low levels of circulating virus at that point. Although there is the caveat that we do seem to be heading into an uptick again. Other numbers seem to be beginning to go up. And there are also lots of other viruses around, and you'll all know many of your relatives will have been unwell, children are unwell, my kids are unwell downstairs. So there's lots of other things that can make you feel very unwell circulating, including flu. So if we move on to the next slide. So this is another level of information about what's going on in the population, and this is a hospital who's been admitted to hospital with COVID. And again, you can see the wiggles over the period of the pandemic. Right on the right hand side, we're quite low at the moment, and so it's a hard number to understand this because it's such a big number. But of every 100,000 people in the population, less than 5 are being admitted to hospital with COVID every week at the moment. Again, seem to be on a slight uptick, but overall the numbers are really low compared to where we were at the peak of the pandemic, where that was, you know, coming up towards 40. And if we move on to the last slide. So this, I haven't got a pretty picture to go with this, but this is some research that we've been doing that in fact we released yesterday, or this morning in fact, and the reference is on the bottom of the screen, or if you look at my Twitter feed, you'll see that I've just tweeted about the paper. So this is specifically about kidney patients. So this is information only about patients who are receiving dialysis and those who've got kidney transplants who are recorded in the UK Renal Registry, which is really complete capture of the population of people who are receiving kidney replacement therapy. And it's the most recent data we have up to August of this year. And in this analysis, we looked at all the people who've been treated for COVID-19 with outpatient treatments, Sotrovimab or Molnupiravir. And we looked at 2,367 of them. And among all those people who were the sickest, potentially the sickest group or the highest risk of severe COVID outcomes, and they've all felt unwell and they've gone to seek treatment. So again, they're probably at the more severe end of the infection spectrum. But among those, only 38 people, or less than 2 in 100, were admitted to hospital. And of those, of the less than 2 in 100 who went to hospital, less than 1 in 4 went on to die of COVID. So again, all of these numbers are subject to change, and it may be that if new variants come along in the future, or if the infection rates in the population go up a lot, that may change. But that's to give you a snapshot of where we are, that of 100 kidney patients who have caught COVID and feel unwell, less than 2 will go into hospital, and of those, less than 1 in 4 will die. So I think it's very encouraging and an awful lot better than we were in the early phases of the pandemic. So that's all for my data, Fiona.
Right, okay, so is that about 1 in 250 then?
About that, yeah.
Overall as the risk there. Right, okay, thank you. Alex, could you just put us all back on the screen, please? Thank you very much. So thank you, Laurie. You've painted a picture there of an improvement since, I was just thinking earlier, 2 years ago, almost to the day, we ran one of these webinars, and it was, I think, the day before, perhaps the day before that, the first ever vaccine was done. So we've come quite a distance since then. But as you said, the risk hasn't, the tools have improved, which has meant that the overall risk has improved, but there's still a risk to people with kidney disease. So thank you for sort of setting that out in context. What we've then done, what we've now done is we're joined this afternoon by David Hayward, who is from the Department of Health. Or David, actually, perhaps it's better if you introduce yourself. You're from the Antivirals Task Force. So I wonder if I could invite you to come onto the screen, please, and just first of all introduce yourself properly, because I've probably done a terrible job there. Sorry for that, but thank you for joining us. And what I think we'd very much like to hear from you, and I'm sure the audience would very much like to hear that, is where we are at the moment with COVID treatments for kidney patients who get COVID, because there have been a number of things that have been going on just recently, both with NICE and with the NHS itself. So perhaps I could ask you just to spend a couple of minutes talking us through that. Thank you very much.
Thanks, Fiona. So to introduce myself, I'm David Hayward, and I'm the Deputy Director for Policy in the Antivirals and Therapeutics Task Force. Very briefly, the task force is similar to the Vaccines Task Force that was, of course, set up to buy vaccines. During the pandemic, the Therapeutics Task Force has bought treatments for COVID, those that have looked particularly promising, and has also worked with the NHS to make those available to patients. And I'll focus on what the current landscape of treatments is, particularly focusing on those treatments that you can get in the community, so that are intended for patients who've just been infected with COVID, and which are intended to prevent severe disease and hospitalisation. So at the moment, treatments are available to a cohort of around 1.8 million patients in England, and this is a cohort of patients who have conditions that put them at higher risk if they become infected with COVID, and that includes a number of immunosuppressive conditions and includes stage 4 and 5 CKD. Patients are firstly eligible for free lateral flow testing. Of course, the population as a whole was eligible for free lateral flow testing, but that ended earlier this year in March. But since then, a number of groups have remained eligible for free testing, including this cohort of patients, so that they can use the testing to access treatments. So there are 4 treatment options available at the moment, which will remain available over this winter. There's the oral antiviral called Paxlovid as a first-line treatment. There's an intravenous antiviral called remdesivir. There's a second oral antiviral called molnupiravir, and then in exceptional cases, the monoclonal antibody sotrovimab can also be given. This is the suite of treatments that's been available for the majority of this year. And it means that there's a choice available to patients and to clinicians. So, for example, molnupiravir can be given to patients who cannot receive Paxlovid. There was a question around how effective these are. I mean, in simple terms, there is good evidence from clinical trials that the antivirals can reduce hospitalisation substantially if they're given quickly, so within around 5 days of symptomatic infection appearing, so within around 5 days of presenting with a positive test. This is also the case for the monoclonal antibody sotrovimab, which had strong clinical trials data, but that data was obtained against older variants. Unfortunately, antibody therapies are potentially less effective against Omicron and other new variants, and in vitro data suggests that could be the case for sotrovimab. And that's why the World Health Organization recently published guidelines recommending that it's not used as a treatment because it may not be effective against Omicron.
David, could I just ask you to explain what in vitro means, please?
In the lab. So clinical trials are normally looking at patients are treated either with the drug or with a placebo if it's a randomized control trial, and then they're able to look at the outcomes from both groups of patients. So that's looking at real outcomes in humans, but in a trial setting. In vitro data is where you're looking at effectively in a petri dish, simplistically, how the drug interacts with the virus, and from that you can draw conclusions around whether it has around what level of effectiveness it has. And what's happened with the monoclonal antibodies, in simple terms and in general terms, is that in the lab they've been seen to be less effective at neutralizing the virus, or at least newer variants. Does that help, Fiona?
Thank you. Yeah, it's just that we've got quite a lay audience, so it'd be just be helpful to know. So also, you were saying that you based that decision. You're basing those thoughts, not you. People are basing those thoughts on some of the data that's been found. Are you considering new data, for example, the sort of data that Laurie was just able to share that's just been published today?
Yes, although I can't comment on the data that's just been published.
No, I realise that,
So,
but
of course. Yeah, so essentially the process has been that a group called Rapid-19 has made recommendations around what drugs we purchase or put into clinical trials. The NHS itself then reviews which drugs actually go into use in the NHS, and which groups of patients should receive them. Back in December last year, when these treatments were first introduced, that was on the basis of clinical trial data that they were effective against the then Delta variant. Over the course of this year, the NHS has needed to keep under review which of these treatments whether these treatments should all remain in use. It's needed to consider in vitro data that suggests that sotrovimab is less effective against Omicron variants. The NHS has, and as I said, the World Health Organization has recently recommended that sotrovimab is not used because of the kind of uncertainty or debate around its effectiveness. The NHS has just gone through a process of looking again at which treatment should remain in use. They have revised the clinical policy and published an updated clinical policy last week, where I appreciate there were concerns that sotrovimab would be withdrawn altogether. And that would provide patients with fewer options. The debate was essentially around should it be withdrawn if it was, was there sufficient concern around its effectiveness against Omicron to withdraw it. Where the NHS has settled is that it remains in use, but it's no longer a first tier option. It remains available for use in exceptional circumstances. And in general, then that will be for patients who are unable to receive Paxlovid and for whom remdesivir or molnupiravir are also not good alternatives.
Right. Okay. So can we just be clear? And also, I think people have worked out the chat's now working because the chat wasn't working earlier. So you'll see if questions start to come up there, because I thought it was strange. We always get hundreds of questions and we had zero. So I think that was just a setting. So apologies for that, everybody listening here. Right. So there's a few things in what you just said, including a lot of names of treatments that people will be asking about. And we can also summarize all of that in the report that we're going to do from the webinar. However, just to be clear at the moment, there is a treatment, and I'll ask Claire, our pharmacist, to comment on this in a minute as well. Of all those treatments that you've named, there is one treatment which is called sotrovimab, which is a treatment that people who get COVID, who have kidney disease, have formally been recommended. And you have just said that at the moment, that treatment is only available on an exceptional basis. Is that correct?
Yes, so it's available to clinicians, but the guidance effectively describes how the other three treatments, Paxlovid, molnupiravir, and remdesivir, are preferred to sotrovimab, but it's still available if the clinician thinks that sotrovimab is the best option for the patient.
Right, so just for super clarity for everybody, that sotrovimab treatment is still available. I know that separately I'll be talking about the fact there is a NICE are also looking at it, but that's not till next year. So that treatment is currently still available. But what people would be saying, and I think they've said that anyway, is that the preferred treatment NHS is talking about at the moment is called Paxlovid. But the point is that at the moment, Paxlovid is not a suitable treatment for people with kidney disease. So does that not create an additional barrier for people who get COVID over this period of time to be able to, given that they have to receive it within 5 days? I wonder if you could just comment on that, and then I'll ask you another question, then we'll also get our pharmacist to join us.
So I think the point is that there's a choice of treatments available because, the cohort of patients includes a variety of conditions. Many people are suitable for Paxlovid, but then, as you say, kidney patients not. So essentially what the thought process would be, is this patient, is Paxlovid a suitable treatment for this patient? If it's not, the clinician is then able to consider the use of remdesivir, molnupiravir, and sotrovimab as alternatives, and in that order of preference.
Right. Okay. So I think I'm probably not alone in saying that, and I think you knew this anyway before you joined us this afternoon, that we in the kidney community and kidney patients and Kidney Care UK are really quite concerned about this. So I suppose I have another question for you right now, which is, what is the plan for people with kidney disease? Is there a plan in terms of protection against COVID?
So the plan is as things currently are, which is that they, along with other patients in the cohort, are eligible for free testing, and then there is this selection of treatments, not all of which will be suitable for them, but there is a choice available to clinicians and therefore ultimately to patients, where for patients where Paxlovid isn't suitable for, there are the 3 other options, including sotrovimab.
Right. Okay. Now we've had a question. Someone just put up about how do you get free tests. I actually checked this last night, and you can go online and get a free test, and we can always put the link up for people to have a look at. But it was working last night, so you can just, my advice on that one would just be to Google it. But I know that's still working at the moment. And kidney patients, later stage kidney people who are immunosuppressed are all still remain eligible for testing. That's right? Yeah, and it is indeed a lateral flow test, as somebody has just said as well. That's the type of test that's out there at the moment. Okay, then will you just stay on the line, and we'll stay on the line, stay there on the screen rather. I think that's probably more for Alex to do. And can I invite our panel, our pharmacist on here, Claire, please? So Claire, just getting you on to join us at the moment. Claire, from your point of view, as a lead pharmacist at the renal pharmacist at the Lister Hospital, if a patient presents as having a positive lateral flow test, which they have either registered online or they've rung 119, which is the 2 things I believe you have to do. You have to do now. Could you just talk us through what would happen and what treatment they would get?
Yeah, so if you are test positive for COVID and you register your test online, as Fiona, you said, you will then pop up onto the portal for the CMDU. The CMDUs are working within each area, and they can
you just say what CMDU is?
COVID Medicines Delivery Unit. You can ask me that. And they're working in every area, and as David said, they're working to the list of patients who fit the criteria to be eligible for COVID-19 treatment, to try and stop the progression of severe COVID and try and prevent them from coming into hospital. So we have, once you've registered your test, you'll then pop up on the portal. The portal then gets looked at daily by a team of people who then triage the patients, looking at when your symptoms started. You have to be within 5 days, and then look to see what treatments we can give you, whether you fit them. And we always phone every patient. So every patient will get a phone call and a discussion through with a clinician. What your symptoms are like, are your symptoms improving, what symptoms do you have? So if you do have symptoms and they're not improving, make sure you do say that when you get the phone call. Otherwise, if you say, oh yes, I'm okay and I'm getting better, then that will be the end of it. But if you are not getting better, do make sure you do say that. And then you'll be triaged to look and see which treatment you can get. So obviously we've got, as David said, Paxlovid is first line, remdesivir is second line, then molnupiravir, and then sotrovimab. And it does suggest there should be an MDT discussion around that. When we've discussed that within our local area and certainly other CMDUs as well, Paxlovid clearly isn't suitable for anybody taking tacrolimus, so you can't do that. Paxlovid also interacts with lots of other medications as well, because it's a very tricky drug to use, very time consuming within the CMDU to make all those discussions and with the patient. You must have good renal function and good liver function. So again, if you've got CKD stage 4 and 5, you're not suitable to have Paxlovid. Remdesivir would be the second one. Again, you're not suitable to have that if you've got a poor renal function. So if your eGFR is less than 30%, you couldn't have remdesivir unless you're on dialysis. Molnupiravir would be another option, or sotrovimab would be another one. So for our transplant and CKD stage 5 and dialysis patients, we would be looking that we can't use Paxlovid. Remdesivir is an option, but not only if you're on dialysis, not if you're poor CKD. And there are also logistical issues around remdesivir. You've got to come in for 3 infusions, and lots of the CMDs don't have capacity for that. So many are not using that. So then you're left with molnupiravir and sotrovimab. And we're certainly looking at the transplant patients to all be getting sotrovimab, and again, the dialysis patients to be getting sotrovimab as well. As looking at the data that Laurie already mentioned, that she's had published today, sotrovimab has been shown to be superior to molnupiravir, reducing the impact of severe progression of severe COVID. So those are the options that we have, and it is really important to register your test.
Right, so the key thing is to register your test. I think my colleagues have put that up on the chat several times. You can also ring, I believe it's 119 to register your test if you can't get online. Now, I can see a lot of you have also been asking about all those treatments and the different names of them, and I realise that there's quite a lot of names in here. We have got that information on our COVID, some of that is on our COVID coronavirus website, and we'll be posting that in the report from this as well. So I think some of the key message there is that the currently recommended, the drug that the NHS is currently saying would be the first drug to use is a drug called Paxlovid, and it is not suitable for kidney patients in general. And that therefore our multidisciplinary teams of professionals, the people you'll be ringing, are going to have to look at the list, and they will still prescribe sotrovimab, which is the drug that in general, and I know I'm speaking very generally here, is more appropriate for more kidney patients, and that will be the key message for this period of time. Is that correct?
You're right, yes, yeah, and certainly sotrovimab is more effective, and Paxlovid and sotrovimab take out the kidney and transplant are more effective against progression of severe COVID.
Right. Okay, now there's a couple of other questions that have come up here. Can you have sotrovimab twice? I'm sure that's come up in my list of questions as well. You can have it
you can.
Twice. Okay, that's good. And
as long as you, not within the same week, but if you were going to have COVID a few months later, then yes, you can have sotrovimab again.
Right. And as others were saying just there, how long will these drugs be available? These drugs are available now.
Yes.
And there is separately a consultation going on with the National Institute of Health and Clinical Excellence, NICE, which is working with the Scottish Medicines Consortium as well. And that will publish its guidance on the use of these medications. At the moment, I believe it's March 2023.
Yeah.
So there will be some other activities in the meantime. And I'd like to thank everybody on the webinar who has been giving us your feedback to put into the this NICE consultation on which drugs to be used. And that goes in on this Wednesday, the 7th of December. Yeah. So if you've got further comments, please don't flash them up here, but send them to policy@kidneycareuk.org, because I'm more likely to remember them. Also, a question that's come up, but it would be helpful if the panelists could just comment on this as well, which is that effectively this is the same in all 4 countries of the United Kingdom, isn't it? Yeah, that's correct. I believe that was the case. Thank you, Claire. Don't go anywhere. But David, can I just? I know you're not, but I wonder, David, can we just ask you what the Department of Health and Social Care is doing in terms of prophylaxis? So rather than the actual treatments themselves, if you get COVID, what about treatments like Evusheld and potentially others to protect us against COVID, which of course I think many people would agree that it'd be far better not to get it in the first place than to get it and get treatment. I'm sure all of us would agree that, actually. Right, David, can I just go back to you for a moment on that, please?
Yeah, so we would agree. And in addition to treatments, there's potentially a really important role for prevention or prophylaxis. Relatively early in the pandemic, I think it was, no, sorry, not that early in the pandemic, but at the start of 2021, we've been doing work on prophylaxis for some time. And that included setting up a clinical trial platform called ProtectV, which is looking at a number of medicines, including sotrovimab, not as a treatment, but as a prophylaxis. and also at a drug called niclosamide. So it's definitely something the department has, we've wanted prophylaxis in our arsenal.
Sorry, I should have said what prophylaxis is. Could you just explain what prophylaxis? Because some people say, what does that mean? So could you just explain that?
Sure. So I mean, this may not be a kind of fully clinically correct description, but I mean, essentially, we're talking about treatments that you can give to people before they become infected with COVID. So before exposure, ideally, and in the case of treatments like Evershed or sotrovimab or other monoclonals, the way it would work conceptually is that the patient is given routine routine injection or however the treatment's administered, perhaps every few months, and then they carry with them a sort of protection against COVID infection. So it could work in a similar way to. It could work as a complement or a supplement to vaccination and confer what's sort of described as passive immunity to the virus, meaning in practice that if you did come into contact with the virus, the patient would be less likely to develop, to either become infected or less likely, or if they did become infected, less likely to develop severe symptoms. And of course, it's desirable to have that in our arsenal. Because particularly for patients who don't respond very well to vaccines. But does anyone want to add anything on the sort of the concept?
Do you want to add anything on those concepts? Are you happy?
No, I think that was very clear on the concept of yeah.
So I would just say in response to a couple of questions that have come up. So one example of for those who aren't aware, one example of a prophylactic or a preventative drug is called Evershed. And that is a drug that many of us have been campaigning for access to over the past few months. It was approved by the Medicines Health Research Agency in March of this year, but unlike some of the other drugs that we've been talking about, if you remember, this is a protection and treatments webinar after all, have gone on to be allowed to be given to patients, but that one has not been. And so I'd like just to ask you, David, so what is the department actually going to do? Because right now there's no access to Evershed. There's been various decisions made. You talked about some other medications, some other things. So I guess it goes back to my question about what is the plan? Where are we with this? And what can your patients look forward to or expect to see coming?
Sure. So I probably should recap the position on Evershed, which is that, as you say, Fiona, is authorised in March by the MHRA, authorised meaning that it was, it then became legal to make it available in the UK in simple terms. When the MHRA authorised it, they were doing so largely on the basis of clinical trial data that showed it was effective at reducing severe symptoms and hospitalisation, but that was data that was obtained against older variants, so this the 2021 variants, and not against Omicron. And there has been uncertainty around how effective Evershed is against Omicron, and that's something the MHRA noted when it issued its authorization. So since then, the department and a range of clinical groups that advise us have basically been making, in the first half of the year, we're making an assessment of whether to procure Evershed or not and make it available, given that uncertainty. In September, we wrote out to Kidney Care UK and to other charities with the results of that process, and we explained that the government wouldn't be procuring Evershed this year and the reasons for that. And that was because the clinical groups advise that there's currently insufficient data on what level of protection Evershed offers in relation to the Omicron variant, and indeed against other new variants that may emerge. That decision was based on independent clinical advice by a group called Rapid C19. So Rapid C19 is a group that was set up at the start of the pandemic and has worked throughout the pandemic to basically assess which treatments the NHS should be made available sort of under pandemic circumstances. So it's been looking at how strong is the evidence base for making a treatment available and making recommendations on which ones we should buy and which ones the NHS should deploy. The sitting on that group are clinicians and experts who work for bodies like NICE, the MHRA, the NHS, so NHS England, and also the National Institute for Health Research. So these are the groups that make all of the day-to-day decisions around medicines being made available, being authorised, or being made available on the NHS. And they've got together to look at the various COVID treatments, including Evershed. Their recommendation was that, as I said, there isn't strong enough evidence of the level of protection it offers against Omicron variants, and they couldn't recommend procuring it or making available on the NHS at the moment. So that's the position that we set out in September, and we published the reports that from Rapid-19, which kind of set out their thinking and their view of the evidence. What we did say in September, and this remains the case, was that we'd referred Evershed for a fuller appraisal to NICE, to the National Institute of Clinical Excellence. So they are currently assessing whether, they're currently forming their own view of Evershed and whether it's clinically effective and cost effective. That process is not a quick process. They're sort of working as hard as they can, but it's a process that will take until April to complete. And then when that process is complete, and as with the NICE appraisal that you were just describing, Fiona, there'll be a consultation process and the opportunity for people to be involved in that. If the recommendation is positive, then as with other NICE recommendations, the drug would be made available on the NHS. Shall I pause there in terms, because those are the main next steps on Evershed. So, I mean, in very simple terms, we've set out that we don't think the evidence is strong enough to support making it available now because of the, insufficient evidence of how effective it is against Omicron variants. It's being reviewed by NICE at the moment, and that will determine whether it's made available next year.
Okay, thank you for your summary. I think you're very well aware that Kidney Care UK and many other colleagues in the kidney community are also disappointed in that decision and think it would have been a far more pragmatic thing to do to allow people to have access to that treatment in the way that access to the other treatments was given earlier in the pandemic. So I think what might be helpful now, because I can see there's a lot of questions coming through on the right-hand side as well. We've got a number of experts on here. I wonder whether Laurie or Michelle would have any comments on what we've talked about so far. And while you come on, I'll just summarise. So at the moment, if you get COVID, there are a range of treatments that are available to people. As a protection against COVID, Evershed is not available, and there are no other currently available medications there for protection. I know we're going to talk about vaccines later, and they play a very important part in this as well. But just in terms of anything else, you mentioned a couple of things there, like Protect V, etc. But I don't know whether any of our colleagues have, whether Laurie or would like to make any comments, and Michelle would like to make any comments on the points that have come up so far, and then we'll dive into some more questions in detail. Laurie, Michelle?
Shall I go first? Thanks, David. I appreciate you're in a quite a difficult position, and thanks for coming along to talk, because it is tricky. And I've been reading the comments in the chat, which are, heartfelt and difficult. And I think I'll say two things. First of all, around the data. David's highlighted the WHO guidelines and some in vitro evidence, the basic science evidence that suggested that setrusumab was less effective. We've published evidence using real data from real patients suggesting that setrusumab remains effective up to fairly recent periods, covering the current variant of COVID that's circulating. And there is also some basic science evidence that suggests that setrusumab is still effective. And the NICE, the current appraisal by NICE and other decision-making bodies are being robustly challenged as to whether they've accepted the correct evidence. And I think all of this, what David's saying, what our evidence is, challenging the way that we make decisions around medicines. They've always been set up for long-term use, And at the moment, we're faced with a situation where we're fighting a virus which is changing very rapidly, where drugs are expensive, and we have to think about those drugs, risks and benefits of giving those drugs, because if we spend money on Stuvimab, we can't spend it on something else, and the NHS is in a difficult financial situation. And that's not to say I agree with the decision, it's just showing how hard it is for the government and decision-making bodies to think about these things. So I totally understand how difficult this is for people, and all I can say is that there's a lot of challenging decisions going on, and fighting for what we think is the right for patients, but also being aware that this is changing the way that we think about drugs in general. And Michelle has got much more wise things to say.
Thank you, Laurie.
No, I don't.
Michelle.
I don't think I have actually. I think it's important to get across that in terms of the monoclonal antibodies, they all have a shelf life, and therefore any prolonged decision making is just not a viable option. And I'm very sorry, David, because you happen to be on the call, but I think the length of time between the MHRA approval and the Department of Health saying, sort of voicing its statement on its position on Evusheld in September was too long. And in NICE, it is probably going to be way too late for Evusheld. I also think it's important that a lot of the in vitro evidence that is being looked at by panels that are weighing up the evidence are looking at one particular lab marker. And this is a lab marker called neutralization, which is basically how powerful the antibody is to bind the virus to prevent it infecting an individual. But antibodies have different properties which will also help protect patients against becoming severely unwell should they become infected, which is perhaps why we're seeing the data that we are with Laurie's data, that's suggesting that perhaps some of the lab data is suggesting it's not quite as effective, but in clinically, because it has the antibodies have lots of different properties, we are seeing a clinical benefit. And I just think that, I think with the population that we are dealing with limited options, I just think we have to act faster than what we have been. And unfortunately, there has been data even during the Omicron period of the efficacy of Evusheld, certainly since the MHRA approval coming out of the other countries. So, it is a shame that the UK hasn't been able to keep up with that, but do acknowledge that there is a shelf life with all these monoclonal antibodies. So it's very difficult to always be producing up-to-date evidence on them.
Thank you, Michelle, and thank you, Laurie, and thank you, David, for all those comments. I can really see there's a lot of discussion going on the side here, so you'll be able to see for yourselves very clearly how people are feeling about all of this. But we think that it's important for us to be able to have these discussions so people can understand what is going on and understand what's available to them at the moment, how they access it, and what the thinking is behind that. But I absolutely agree with you, Michelle, that some of the speediness that has shown itself at some parts of the pandemic needs to continue, because for us, it may be at a slightly different stage, but it still has an impact on people with kidney disease, and that's hence the discussions here today. So I wonder if I can perhaps, as I've got you on the screen there, Michelle, there are a couple of questions that followed directly on from this that I could ask you, which is, you heard David speak a little bit about Protect-V and a couple of the other treatments on the pipeline. Have you got any update on any of those treatments that you can share with us?
No, I'm not aware of there being any new agents ready for clinical rollout. I think the focus is actually we've got quite a large arsenal of therapies. Which ones are going to be best in protecting individuals? I think there is a caveat, as I've said, with the monoclonal antibodies, because the pharmaceutical companies will always need to continue adapting them as the virus continues to change. I suppose what is currently being tested still is, which is I still think of interest and used in the America is the convalescent plasma for patients who become unwell and come into hospital. So what this means is that these are a concentrated form of good antibodies against people who've recovered from infection and therefore are effective against the circulating variants. So they're a different way of providing the monoclonal sort of antibody therapy, and that they're currently being tested at the moment. And I think, I do think that prevention is the key. So, trying to work out the different vaccine combinations. There's nasal vaccines that are being looked at to try and optimize prevention in the first place. And I think that's key. I think as soon as the Protect V study publishes its results on the niclosamide, which David has already mentioned, that may have an impact on clinical management of patients. And there is a study also going on with Evusheld, that's open at the moment, called Rapid Protection, but that is just recruiting patients all to Evusheld rather than having a control arm of patients who don't receive Evusheld. But yes, it's very much focusing with all the drugs we have at the moment, what is the best treatment to prevent people becoming ill should they get infection, but also the importance of continue to evolve the vaccines, the different vaccines, different combinations for our populations.
Okay, and this was on my list of questions to ask, but I can see it's also popped up in the chat there. Sorry, just one thing. Some people have been asking about vaccines. We're going to, you haven't missed that. We're going to move on to talk about vaccines in a bit. So, but just in terms of those studies that you just talked about, the possible studies, you mentioned the Rapid Protection study, that is online, so people can look that up. That's recruiting people now to be tested with Evusheld. But you also mentioned the sort of preventive nasal spray and things like that. Do we have any dates as to when any of those studies might be published and potentially turn into treatment for more people?
Yeah, I can't give you timelines. So this is being run out of Cambridge. I know they've recruited almost 1,500 patients now with kidney disease and other sort of immunocompromising conditions. But they're also randomizing to a second arm, which is the sotrovimab, so it's slightly higher dose than they use for treatment for patients. And I know they're still actively recruiting to that arm currently. But I'm unable, I'm afraid, to let you know when any data is going to be emerging from them.
Okay, thank you. And anything that you want to mention from either the Octave study, which some people may have taken part in, or indeed the Melody study, which both looked at levels of antibody protection and what's happening in kidney patients? Any dates or updates you can give us from those, Michelle?
Yeah, of course. So I've with a team run the Melody study, and we think this is an important study. We appreciate greatly all the patients who've taken part in that. So this was the home testing antibody study, where patients with different forms of immunocompromising conditions, the hematological malignancies, people with autoimmune disease receiving treatments such as rituximab, and then transplant patients all received a kit to test at home whether or not they had antibody or no antibody after at least 3 vaccines, but anywhere up to 5 vaccines. That finished recruiting in June, and we're currently in follow-up in terms of the correlation between those antibody results and infection. We're hoping to report the baseline sort of information, well, we're hoping even before Christmas, and then the infection data will follow before spring. So hopefully in time for or before the NICE publish its guidelines on recommendation for Evusheld, because I think it'll be important to help in terms of forward planning in protection for this population.
Brilliant. Thank you very much for that. I'm sure that people will really be interested in that. Got so many questions coming up here. There was just one other question that my colleague just prompted me to ask. I've just better check that. No, I think I'm going to come back to that one later. Actually, I've just realised I can't look at all the questions at the same time. So what I'm going to do is there's a few common questions that have come up, and what we'll do is we'll try and round those back up again as we run through, not to miss them. But we've also got, many of you have asked a lot of other important questions during the webinar as well, so or in preparation for the webinar. So I want to give time to those. So I think we've talked a bit about the current risk. We've talked a bit about sort of the current situation. I know that people have very strong opinions on that in terms of access to treatments, in terms of access to protection. And we talked a little bit, we just touched on some of the, so how you access those treatments, some of the possible new treatments that are in the pipeline as well. I'm going to, I think, just now, just further comment, or just ask my panel really to comment, because there's a lot of questions come up further about Evusheld. It is worth mentioning, and people will realise that drug is available privately, but in the middle of a cost of living crisis, that's a very, very tricky thing, because there's quite a cost to it, and we very much wish that we were not in that situation. In terms of kidney doctors being able to help people, to refer people to get Evusheld, or pharmacists, are any of our panel able to comment on that? I've not heard of any hospital that's able to do that. It would have to be people going privately. But could any of it, or if you happen to have, which I doubt anybody does, but private healthcare, because it is available but through some policies that way. So I wonder if anyone in the panel could just comment on that, because we've had questions. Michelle, it's like you.
Yeah, I mean, I think this is the most heartbreaking thing, actually. This is I mean, I understand if Evusheld's not available, but it shouldn't be available for everybody. I don't think a cost should be put on this. In terms of access, I'm not aware of any kidney doctor in London. There are lots of private hospitals who might be able to put people in contact with providers, and it would probably be a specialist in the area of immunosuppression who might be able to deliver this. But I suppose it's contacting the local private hospital and asking. I'm sure they are getting some requests, unfortunately.
Mm-hmm. Okay, thank you.
Sorry, I can't help.
Yeah, Laurie, have you got any comments?
I share Michelle's opinion that this is just totally heartbreaking, but I think for people who are really struggling to afford it, the evidence that it's now effective is so marginal, and there is new evidence coming very soon. I mean, what can I say? I spoke to an expert virologist recently who said if I was a transplant patient, I wouldn't get Evusheld now. But
has the boat passed?
Heartrending decisions that people are going through.
That's the question, isn't it? Has the boat passed for some people? And we don't know the answer to that. That's really, I wish we were not in this situation. I really, really do. It's incredibly difficult. And we will continue to advocate as far as we possibly can for people with kidney disease as we go through this. We need to address a few of the other important questions that people came up with for this webinar, which are some of the protections that we do have, some of the things that we can do for ourselves. And there's also quite an important question about how COVID affects the kidneys. So I think what I'd like to do is just go to Claire, if I may, just to raise that question about how COVID-19 is spread, what the current understanding of that might be. So Claire, over to you, please.
Thank you, Fiona. So so COVID-19, as we all know, is spread in droplets. So it's spread if people are breathing or coughing. Obviously, if you're then speaking, you're close to people. So if you've got close contact with people who's got COVID and they're breathing or coughing over you, you're likely to breathe it in. Equally, if they then breathe it and cough it onto surfaces and you then touch those and touch that in your mouth, then you're likely to pick it up that way as well. So I think if you're at risk of doing poorly with COVID, then making sure that you're washing your hands regularly, staying clear of people, and maybe keeping away from crowded spaces where people are coughing and spluttering would be a way to get around not picking it up. But it's spread through droplets and touch.
Right. Okay. And there was a question about wiping down shopping.
I wouldn't wipe down shopping. I would think if you're going to then I think it's about the risk. Laurie's talked about the risk being less now than it was previously. So it's about looking at the bigger picture and about the risk for yourself and the risk in the population. Washing your hands, but I wouldn't be washing shopping. Keeping it somewhere safe. You know, the virus isn't going to live on the surface forever.
Right. Okay. Let's just go to a little bit about how COVID affects the kidneys. So I think this one was for you, Michelle. How does I've very recently had a kidney transplant. How badly affected would I be if I get COVID? So someone who's probably within the first few months of a transplant.
Yeah, so we know that if you are vaccinated prior to transplantation, actually that will provide protection afterwards. The biggest impact in terms of transplantation was pre-vaccine, and then the patients who were freshly immunosuppressed who were receiving the vaccine during the first couple of months. But we do know that prior to immunosuppression, and it's very important, I think most centres, whether or not it's transplantation or any other form of immunosuppression, will make sure that you are, or you should make sure that you're up to date in terms of your vaccination. So all the vaccinations you are eligible for prior to starting immunosuppression if you can.
Thank you. Okay, and there's quite a few vaccine questions here we're definitely coming on to. Laurie, does COVID reduce your kidney function?
So again, the risk of this has changed. So many of you will remember lots of really heartbreaking stories at the beginning of the pandemic of lots of patients suffering severe kidney problems and going on to dialysis at the as a result of COVID. And that the risk of severe outcomes from COVID has improved as the risk of all outcomes from COVID has improved over the time period. Obviously, all infections can significantly reduce your kidney function, and we have always seen patients who are very unwell with infections have drops in their kidney function, and some patients who are close to dialysis being precipitated onto dialysis as a result of the infection, and COVID is the same. But overall, the risks are much lower than they were. I don't know, am I allowed to hand over to Michelle to double check that she agrees with that?
Of course.
Completely agree, and it's the same for transplantation as well. So transplant patients who are affected, so much better now than prior to vaccination, because patients are becoming less unwell, which is a positive thing.
So are we also saying therefore that I'm sure I remember being told this myself, that if you get an infection, regardless of what the infection is, that people who have kidney disease, it can unfortunately bring them on. It can cause damage to your kidneys, regardless of which can, if you're on the brink, tip you into dialysis or affect your kidney function, because that is what happens when any of us get an infection, full stop. Yeah, is that right? I mean, I know COVID is the infection we're talking about, but it could also apply to a respiratory infection or something else as well.
Yes, it can. Yeah.
Right.
Yeah.
Okay. Thank you. And can COVID lead to kidney disease in people who haven't had it previously? So I guess that would be people who'd had a kidney injury and could be left with some level of kidney problems after COVID.
Yeah, so very similar to what I was saying earlier. Certainly at the beginning of the pandemic, there were people who were being really shifted in their kidney function or even onto dialysis from very good levels of kidney function. That's unusual now. It's just as you were saying, Fiona, that it's some people with better kidney function will have minor drops, which will then improve again afterwards. Some people will be precipitated, but not different to any other infection.
Okay, so just to round that one up, so does catching COVID put my transplant at risk? Michelle,
yes, but I think much better now than pre-vaccine. So if you are fully vaccinated, even as a transplant patient, your risk of getting very unwell with COVID is dramatically reduced, which therefore makes it less likely that your transplant function is going to deteriorate for after the infection.
Okay, thank you. Right, so Laurie, what sort of precautions should we be taking now? Should I still wear a mask if I'm on dialysis, have a transplant?
So I think we'll all have a little bit of useful input here. I think a lot of this goes back to to what I was saying at the beginning about having some realistic awareness of the risks, and the severity of illness and the risk of death and so on is so much lower than it was, and so that may affect people's ability to go out and socialise and so on. However, it sounds as though in the chat people are extremely well aware of specific vulnerabilities that they have, that they may have made no antibody response, or they may be highly immunosuppressed, and that is people are clearly highly aware of that and are taking different decisions based on that higher level of knowledge and of their own vulnerability. It's a difficult time because the way we manage risk has changed. So at the beginning, everybody went into lockdown. We all took steps to minimise the risk of transmission to other people. But now the way the pandemic has gone is we've gone back to normal life, which means that people who are at very low risk of severe outcomes, who've got very healthy functioning immune systems, can carry on as normal, and it passes the risk onto the immunosuppressed population. And I think that affects how we manage risk. So in the beginning, we all wore masks because it reduced the overall population transmission. But now people have to take their own individual decisions about how they're going to minimise risk. So that might be wearing a much more effective FFP type mask to prevent their own risk, to reduce their own risk of infection, and in the way they socialise. And obviously in terms of vaccination as well, which is clearly being discussed, and I'm sure we'll come back to in a minute. Okay. Michelle, is there anything you want to add to that, or Claire?
I think that, I think you're absolutely spot on. And actually, I think going into this winter, there are a lot of viruses, not just COVID, around. So actually additional precautions, for example, travelling in, being based in London, the tubes and the buses are always jam-packed. Wearing a mask still on public transport is probably advisable to protect yourself against all sort of infections, not just COVID. And I do think that although the majority aren't wearing them on public transport, there are still a small minority that are, including myself when I travel.
Yeah, me too. I know that's not so many. Okay, there's a really important question here. Do people still need to shield? Sorry, team.
It's an individual decision.
For many people, their response to the virus will be better than they think it will be, and so many people who were extremely concerned about having COVID have actually now had it, and it's not been as bad as they anticipated. But nonetheless, there will be a very small number, as you saw. Extremely unusually, there will be people who have extremely severe outcomes from COVID. And Michelle's probably best placed to talk about how we can predict who those people are. But, clearly the balance of, your financial situation, your understanding of your individual risk are going to impact on the level of socialising and mixing that you think is right for you. Michelle, do you want to talk about individual risk?
Yeah, well, and just before I do, I think shielding did cause a lot of problems in terms of mental well-being, mental health issues, actually exacerbating anxiety. And I suppose it depends upon how you define shielding. I don't think anybody needs to be completely locked in their houses without any contact with anybody. But sort of taking sensible precautions and building up your confidence of contact with other people. Of course, should the rates of COVID infection go up, sort of maybe perhaps during peak times, then reconsider what your level of activity is during those periods. But certainly, I think that the patients who I would still be very concerned about are the ones that are the most immunosuppressed in terms of infection and outcome following infection. And Andrew Frankel's been on the webinar many times before, and he used to say back in his day, he used to say all transplant patients used to be told, you know, for the first year, you've got to be cautious about actually in infection risk, because that's when it's at the highest. Yeah. Because your immune system is at its weakest.
Yeah. Okay, thank you. And I think that there's a few more questions to come back to there, but I'm very well aware of our time and we need to talk about vaccines as well. So I'm going to, first of all, we've had several questions about, are vaccines safe and are they effective? So I'm going to invite Claire, if that's okay, just to comment on whether there are particular side effects on the COVID and the flu vaccine. And just there's a couple of another question that's aligned with that about some people having varied reactions, and do you recommend that they have the autumn one, as that's worrying them? So first question is, what side effects from the COVID and flu vaccines cause people with chronic kidney disease? And the second one is, effectively, I've had a couple of reactions, do you recommend the autumn one?
Thank you, Fiona. So yes, all vaccines can cause side effects in some people, as can all medications, but the common side effects seem to be headaches, injection site soreness, chills, aches and pains, and some people get rigors and stuff after them as well. And that is fairly common in lots of people to have side effects from the COVID or the flu vaccine. I would still advocate having a vaccine. I still think that vaccination is the way forward in order to try and protect ourselves and everybody. So yes, I think even if you've had reactions before, now if you've had reactions before, it depends what reaction you've had as to whether you should have your COVID vaccine again. If you've had aches and pains and chills, then yes, have another COVID vaccine, take your paracetamol and it will pass, and it's almost a sign the vaccine's working. So yes, you should have it again. If you've had more of a sort of an anaphylactic reaction to the vaccine, so if you've had swelling of the lips and face and the airways, then you shouldn't be having the vaccine again. But there are other vaccines that you could perhaps have, there are anaphylaxis clinics available for vaccination centres that are looking at using other licensed vaccines in place for those people that have had those sort of reactions. But if it's a sort of a normal sort of reaction to the vaccine, headaches, etc., yes, you should have your vaccine again.
Right. So if someone gets a particular reaction, do you recommend they speak to a specialist pharmacist or their local pharmacist?
Yeah.
Which one would you say to speak to?
So you could, if you're a kidney patient, speak to your local, you could speak to your secondary care pharmacist in the hospital. They will probably then direct you through to your GP that can refer you in to have a vaccine in one of their vaccination clinics that are for people who have had anaphylaxis type reactions to COVID vaccine.
Can I get COVID from the vaccine?
No, the COVID vaccination is not a live vaccine, so it's safe for people with transplants who shouldn't have live vaccines, and equally you can't get COVID from the vaccine.
Have they been tried and tested long enough for them to be used with confidence, the COVID vaccines?
Yes, there was lots of talk at the beginning, wasn't there, about how they were rushed through and how they weren't tested properly. They have been tested properly. They've just been tested in parallel, looking at all the different systems and ways of testing happened at the same time rather than one after another, which happens normally. So yes, they were tested faster, but yes, they have had all the testing done. And obviously they've been around for a lot longer now as well. So we've got real world data as well as the trial data. So yes, they have been.
And is it safe to take one after a transplant?
Yes, equally, yes, we should be vaccinating anyone who's had a transplant should be having the COVID vaccine, like you should be vaccinated for flu as well.
Do you know how long you should wait after a transplant before getting a vaccine?
Michelle could probably answer that better than me. I don't actually transplant at my centre. You probably shouldn't have one within perhaps a month of being transplanted, Michelle.
Yeah, there's no hard evidence. The general consensus is any time from 4 weeks onwards. Yeah, there's no hard evidence for that at present.
Is it safe to take a vaccine if you've got a kidney transplant? Michelle,
yes, definitely. In terms of the biggest threat continues to be infection. Vaccination in all the studies, and when there's been close monitoring, I think most people are most concerned about rejection episodes following vaccination, but there's no evidence in terms of systematic review in terms of an association between the vaccine and rejection.
Okay, thank you. Do we know, Michelle, as you're on here, do we know how much protection the vaccine gives to kidney patients?
Yes, and it's very well. I think the as Laurie presented the data in terms of outcomes following infection and different how the CKD stages progress and transplantation. I think it's difficult to say, you're always trying to catch up because of the boosters, and we haven't got any data that I'm aware of, unless Laurie knows any, on the efficacy following the new bivalent vaccine, which is the most recent one, and data on that will be coming soon. But what we do know is that with each booster, it seems to be getting more and more effective in terms of protection against severe infection, which is good news.
And just on that question about boosters, so I don't forget, do we know anything about the 2023 programme for vaccines yet? Claire, maybe?
No, I haven't seen what's happening next year. I was just having a quick Google while we were talking about whether there will be a plan. I don't know what the plan is yet.
Okay, well, if you see what the plan is, to just jump in with that in a moment. Okay, so back to Michelle. Is there any research on T-cell immunity? Not everyone has got that.
Sorry, Fiona, Laurie had her hand up.
Well, I beg your pardon. I didn't see that. Laurie, please.
Well, just to kind of follow on from what you were both saying, there's lots and lots of questions in the chat about, having to have serial vaccines. And the importance of the serial vaccine is not that the vaccines, obviously for some people this is different, but for most people, it's not that the vaccines haven't worked. It's just that immunity to cold type viruses like the SARS-CoV-2 virus is quite short-lived, and so it's constantly wearing off. And in one way you can see that's really terrible, but on another way we've always recommended that kidney transplant patients and CKD patients get annual flu vaccines, and so this will probably be a similar type of thing in the long run, where we will have annual COVID and flu vaccines attuned to the latest type, or what we think is going to be the latest type. So I know it probably feels really never ending at the moment, but hopefully this is settling into a routine that will be to some extent familiar and manageable. Thank
you. So we can sort of anticipate, which is kind of what I'd imagined, a sort of an annual type of update on that. I don't know if David is still here from the Department of Health and Social Care teams. You don't know of what the plans are for 2023, as we've got you on here? You may not, but if not.
So I'm confirming I'm here, but I'm afraid I can't talk about the plans for 2023.
Okay, all right. Okay, thank you. So we're anticipating eventually a set of annual jabs. Is that right? Yeah. Okay. Now some people have asked quite a lot of questions about. So someone has said, now I've had flu, pneumococcal, and the COVID booster. Are the risks of catching COVID reduced, or should I continue to be careful? I think that's probably one for you as well, actually, Michelle. Sorry about that.
No, it's good news if you've had all 3 vaccines, because actually you stand a better chance in terms of protection or maximising that protection. There is still a risk of COVID infection following vaccination, but your risk of severe infection is much less following the vaccine. So overall, it's good that you've had them.
Okay, thank you. And I mean, we at the charity, our view has been, give us all the tools to protect us against COVID, and if one of the tools is vaccination, so continue to take those as you're offered them would be our recommendation. Can we just talk about antibody testing, please, Michelle? There's a range of questions that have come up, and they came up in advance as well. Some people, know their antibody status. Some people don't. Is there any possibility of people receiving routine antibody tests to see what level of immunity they may have, and perhaps comment on what some of the different trusts are doing, which is quite some variation there?
Yeah, and I suppose I suspect David will have something to say on this as well. So I, from a personal perspective, I think the antibody tests are useful, but the MELODY study will be able to inform about its use, certainly in the population that it studied. And I know that the Department of Health, from the letter from Steve Barclay in September, still wanted to do ongoing studies in terms of the utility of antibody testing. The reason why I think it is a useful test is because it is a marker about how immunosuppressed an individual is. So I think it is useful in that respect, which is what the MELODY study aims to answer. What's a little bit less clear is what happens for patients who have an antibody response. What does that mean? And that is a little bit more tricky to answer, but it's certainly for the transplant recipients and other immunosuppressed populations. I think knowing whether or not you have a response or not just is a marker of how immunosuppressed you are. And at the moment, I think there is a variation amongst the trusts with regards to clinical detection of antibodies. I am aware that at least a handful of trusts are doing them as clinical routine, but that's not universal. And it'd be quite nice to have an answer either way, so there's less of a postcode lottery, and an evidence base to deliver them.
Yeah, there definitely is, isn't there? Can you make any recommendations? I appreciate you might not be able to on what antibody test people should be taking if they take their own.
Yeah, it's different. I think at this stage, I think it's probably worth waiting now, because the population would have been past their 6th dose of vaccine before hopefully they have the 7th. They'll know whether or not we should be advising antibody tests routinely or not. But they are available. They can ask their healthcare practitioner, or again, I think people can go privately should they wish, but I really don't. I don't think there's enough evidence for that. I think I would hold fire at the moment.
Okay, thank you. And David, that does prompt me to ask you a question, which is there a plan in terms of antibody testing? I know you spoke about that privately previously, and I don't know if you can comment on that.
Yeah, so we're interested definitely in the use of antibody testing, so that patients could potentially receive an antibody test, and then on the basis of that test be given more personalised information about their level of protection and risk from COVID following vaccination, and then that could lead to to public health guidance to those patients. I mean, in practical terms, it would help people understand how protected they were. It would help with individual decisions. It would hopefully be reassuring to a number of patients, and it might help prioritise other patients for treatment or other interventions.
So is there a particular plan that's going to go ahead?
Yeah, so in terms of actually getting there, what we're starting with is the pilot that we trailed in the letter from the Secretary of State in September. So we're working with antibody testing experts, including the MELODY and Octave studies, to develop a study which would build upon existing data and research infrastructure to basically sharpen up the evidence base obtained from those studies, and also against current variants, for understanding how an antibody test predicts level of risk from COVID.
Well, are there timelines for that piece of work?
So I think we're looking at something that can launch quickly. Before Christmas or in the new year, and that would then obviously it would then take some time to run, but the aim would be to be supporting the actual use of antibody testing in 2023 ideally, but at the moment we're in the pilot phase.
Okay, so I'm sure there'll be lots of patients shouting at the screen to say, when will that be, when can I know, and how will that help me? So we only have 5 minutes left of the webinar, so I wonder if there's anything you could give us in writing that we can use to publish with the report of this, that kind of summarises what that plan might be, as you know it at the moment.
Sure. So we can follow up with you. I mean, at the moment we're as I said, we're working with the Octave and MELODY studies and other experts,
which is good,
to basically to finalise this pilot, and we will hopefully soon be in a position to say more about it.
Okay. All right, thank you. Okay, thank you. A couple of other questions that have come here. One's for you, Claire. Which vaccine is best? Is there a particular recommendation?
No, I think you should have whichever vaccine is being offered in your site, unless you've had an anaphylactic reaction to a previous vaccine.
And is there any variation on that if you have diabetes or some other, or
No.
transplant? No?
No, shouldn't make a difference, no.
Okay. And what about someone who suffered myocardial injuries from a spike?
So if you've had reactions like that, then I would go to your GP and see whether you can get yourself referred to the anaphylactic. They're calling them the anaphylactic COVID reactions, COVID centres, but it's somebody who's had a reaction like that to a previous vaccine should go and perhaps have one of the other ones. There's another one available.
Thank you very much indeed. Thank you. I want to clarify, so I could ask you, unless anyone else has any comments on this, is there a lasting vaccine being developed?
So not that I'm aware at the moment, but there are things in the pipeline, and there are other vaccines being looked at, and there is a longer acting one being looked at, but I don't know when that's going to be available. I haven't heard anything.
Right. Okay. Okay. Thank you. And now I wonder if I could just invite Laurie back in. Well, everyone, of course, is welcome on all of this, but there are a couple of other questions about, and they're really for people about, you know, in specific situations, worrying about what to do next, or what to do now even. So is there any particular protection advice you can give around going out and socializing this Christmas? Because it is the third Christmas now, I guess. It must be, yeah, it is the third Christmas.
I was trying to remember, Chris Whitty put this really well last Christmas, something about your social spending. So you have to think about what really matters to you, and also what do you think your individual level of risk is. So if you've had COVID before and you're otherwise healthy, then, you know, perhaps your risk is, you don't need to be so worried about socializing. If you have lots of other health problems and you think you may have not made a good response to vaccines, then your assessment of your risk might be different. So what is it that you really want to do? Is it that you really want to see your family on Christmas Day, or do you really want to go to the Christmas party? And you have to weigh up the risks and benefits of each of those, and focus on the things that are most important to you and those around you. It's very hard. I mean, it's, you know, even for people without any of these health concerns, it's also tricky about, you know, how often should we visit elderly relatives? So it's a problem for everyone, I hope.
Yeah. Any thoughts about meeting people indoors? Keep the windows open, it's freezing.
I think it depends on how well you know those people. I mean, I'll still be doing lateral flows before I go and see elderly relatives over Christmas, and, you know, if the kids were sick, I would think very seriously about going to see them. I think it is once you've got indoors and you've had a glass of wine, it is hard to keep those ventilation.
It is, isn't it? Yeah. Yeah, and I think there's a question here about public transport. We talked about that a little bit before with Michelle about keeping trying to keep a mask on, if possible, travel at the less busy times. Any thoughts on traveling overseas, taking aeroplanes, anything like that? Obviously, masking.
Yeah, all of these things, they all come back to how much do you want to do it. And if a foreign holiday is really important, then that may be where you focus all of your risk, so to speak, your risk spending. But, you know, clearly minimizing the risk as much as you can in transport there and masking on the plane, all of those things are going to be things that are worth doing because they're low impact.
Thank you. And there's one more for you, and then I've got one for Michelle if I just try and sneak that in before we end. Just for people working, is that for people? What would you recommend for people, especially people who's in lots of, we've heard this all the way through the pandemic, actually, people who have a lot of contact with children, nurseries, that kind of thing, working there?
Gosh, so
yeah, I know, it's so hard.
So we do know that, you know, being around children is associated with an increased risk of infection, both of COVID and of a whole range of viruses. In general, people who've worked with children for many years have got very robust immune systems and have got extremely strong immunity to most viral infections. And, you know, so long as they're keeping up with their vaccinations, that's as much as you can do. But you know, if that's your job and that's your only option, you know, hope we are now in a much better place than we were 3 years ago.
Yeah, thank you, and that's more than fair. A few questions, Michelle. I think you said it earlier about joining the Melody study. The Melody study is now closed, isn't it? So we're just looking at the results of that as to.
Yeah, it's just in the follow-up phase, but actually the follow-up phase finishes this month as well. So hopefully be able to report very soon.
And as we've said, the results from that would be used in this potential work with the Department of Health and Social Care.
I'm hoping.
Potential.
I think so. Well, I mean, there isn't a bigger study on immunocompromised patients, so I think I think it will be of great interest.
Right. Okay. Thank you. So we've covered so many things this afternoon. Would any panel member like to use the last 1 minute that we don't actually have before I round up to give us any further comments? Because we've talked about the antibodies, we've talked about some of the research that's around at the moment. We've spoken about the medications that are currently still available to you. We've been clear that some of those we've discussed the fact that they may change in future, but at the moment they're still available to you, and that you'd have the support of your medical renal staff to be able to receive those if you get COVID. A little bit about what you can do for yourself, something about quite a bit about the vaccines set. I believe I'm on jab number 8. I personally encourage anybody to take a vaccine if you can, because we need all the protection that we can possibly get. And it's a tool that's been offered to us. So has anyone else got anything they'd like to add to what we've just talked about before I wrap it up? Anything you feel that be useful to say?
I could do one line, which is that things are an awful lot better than they were, and there's really good evidence that's very easily accessible on the internet about what the current level of risk is. And so many people over the last few months have relaxed what they've been doing and been able to live more of a normal life, and that has been tremendously important to their psychological health. As we head into winter, things will change, but there are good treatments, vaccines are effective, and keep an eye on the information on the internet to show you how the infection rates are changing.
Thank you very much. And it's my 6th jab, not my 8th jab, someone was asking. I definitely haven't had 8 for COVID, just 6 as a transplant recipient. So if we could, Alex, if I could ask you just to go to the last slide, well, I would like to thank all of our participants, well, the second to last slide, I think it is, the one with the, just with some links for people. I'd like to give a huge thank you on behalf of everybody listening. I know we've covered so much here, but Claire Morledge, our expert renal pharmacist, Laurie Tomlinson, our expert epidemiologist, and person who's all about risk, that's brilliant. Michelle, who's been here, done many of these already, but talking about the research, the risk, what's been going on there. And of course, David, thank you for coming on. That probably wasn't that easy for you, but at least to tell us a bit about what Department of Health and Social Care are doing. All of you for listening in and asking all your questions, for sending us your questions and working with us. Everything that you do, everything you send us, we do use all of that responses we make, and it powers us to continue to do what we do at Kidney Care UK. Just to summarise up, for your personal medical questions, do talk to your own kidney team. We've got general advice and guidance on COVID there on the kidneycareuk.org coronavirus webpage. If you need emotional support, advocacy or financial support, that's there on the Kidney Care UK website. We've got cost of living support for you as well. We do recognise this is the middle of a cost of living crisis as well as the pandemic going on. And we've got mindfulness tips for you as well. If we could just go to the very last slide, please. We'll send you this anyway afterwards. But we have a short survey that's there, but it will also go out in the feedback forms from this webinar. We'll be sharing a recording of this if you want to go back to any of it, and we'll be sharing a report which writes up the many phases of the conversation. So take care, everybody. Thank you very much for your time. Thank you very much for all of your questions. Keep going, and we'll see you all soon and hope to hear from you in due course. So good night to everybody, from the panelists, from everybody here at Kidney Care UK, and thanks all for listening. Bye for now.